Hello? Yes. All right. Welcome back. So this is another topical session on another really important topic, which is access to health, inclusive health. Again, I'm really pleased to invite Carlos and Leandro, who are part of the Brazilian mafia. There's this very strong crowd of Brazilian scholars who are working on lots of interesting topics in the sustainability field. So we have a few of them here in the room. So Leandro, Carlos, and then we also have Jafar. Please, Jafar, come and join us on stage. So Jafar is made it all the way from Morocco last night and is flying back this afternoon just for, just come here. He just came for us. So thank you, Jafar, for the effort. And Jafar is a real expert in health, a professor, an epidemiologist, and a policymaker, influencer on health issues in Morocco. So very pleased to have him. Again, the format is the same. He will rebound on what he has heard. Just two words about the two papers. So Carlos's paper is taking us inside, hospitals and how decisions are made by medical experts, and is actually showing how influential these decisions, how malleable those decisions are, and how peer pressure and how the teams that doctors work with actually influence important consequential decisions they make at work. So very cool behavioral paper. And then we have a very different paper, which is that of Leandro, also very cool, but is actually looking at electronic medical records. Which country again? Malawi, okay. And there it's really looking at the efficacy of this kind of, and how it affects privacy issues and how it may affect access to health. In a nutshell, two very cool papers. The floor is yours, Carlos. You start, and then we hand it over to Leandro. Let me. Okay.
All right, can you all hear me? Yeah. Thank you so much. I'm so excited to be here and present my work on peer influence in the workplace. I'm looking at specifically at peer effects among OBGYNs and their decisions to perform either C-sections or vaginal delivery. So this is joint work with Jillian Chow and Northwestern. And in the context is like public sector, public healthcare system in Brazil. All right, so.
Oh. Try again now.
I'll go.
Sorry.
Yeah, I can use.
It's fine. Oh no, sorry. Maybe use the clip.
Sure.
Use this. Sorry. Up and down.
Perfect. Thank you. All right, so there is a rising C-section globally, right? So if you look at this chart, on the top left corner, you see that C-section rate went from about 10% in 2000 to more than 20% in 2020 worldwide. There is large variation across different regions. So if you look at, for example, Northern Africa, the C-section rate went from about 10% in 2000 to more than 35% in 2020. Similar increase in Eastern Asia, if you look at...
That would be just perfect.
Thank you.
Thank you, I'm sorry.
So similar trend in Eastern Asia. So if you look at the rate in 2000, it went from like about 10% to over 40%. Also, large increases in Latin America. So the C-section rate was already very high in 2000, so over 30%, and now more close to 50%. Southern Europe also seeing similar increases, right? So overall, large increases in C-section rate in the world. I was checking Morocco, Jafar, and I think the C-section rate there went from something like 5% in 2004 to close to 20% in recent years. So large increase in C-section rates. So we know that, C-sections can be life-saving, right? But unnecessary C-sections incur potential costs for mothers, potential risks, including longer recovery times, including increasing rate of complications, and higher healthcare costs. So there are many factors that might contribute to these trends, so increasing rates of C-section, including changes in demographic characteristics, changes in lifestyle, financial considerations, physician training. Among these factors, peer influence or peer facts in the workplace is often cited as a potential contributor to growing rates of C-section. So when I say peer facts, so that means the influence that your peer physicians have on your own clinical decisions and practices in the workplace. Okay? So peer influence can actually be quite powerful in explaining these increasing rates of C-section. Imagine that this works as like a spillover, right? So it affects you, it can affect you back, and so forth. So understanding the role of peer facts among OBGYNs has a potential significance for understanding these trends. In the literature, I think there is a long-standing interest in the role of peer influence in the workplace, right? So across many social fields, people are interested in how your peers might shape your own behavior and your productivity. There is a large body of work on peer influence in the lab or in education. There is relatively less work on peer influence in the workplace, so in real-world settings of people actually performing a certain type of work. Existing work is often limited to a single organization, is concentrated in more routine work. So existing evidence for expert workers is both limited and mixed, indicating that there are certain studies that show the existence of peer facts and some others saying that there's basically nothing. So although we understand the role of peer influence in specific settings, research indicates that social influence is not universal and its effect may vary depending on the context. So I think we still have limited knowledge of peer influence across organizational contexts, specifically thinking about more expert work. So the research question in this project is, how does working alongside peers who favor C-sections impact your own likelihood, the focal physician likelihood to perform a C-section? Our specific setting is the public healthcare system in Brazil, and I will tell you in 2 slides why we focus on this specific setting. So Brazil has one of the highest rates of C-sections in the world. The average rate in the country is approximately 55%. It is the highest among 139 countries from between 2007 and 2012. Just to put that into perspective, the WHO recommendation is to have an average rate of C-section between 10 to 15%. So super high. And it's not only Brazil, right? So some more recent statistics indicate that C-section rates in countries like Republican Dominican, Egypt, Turkey, Chile, they're also high, all above 40%. Even in countries like, US, you have an average C-section rate of above 30%. So again, understanding the contributors to this such high rates is very important. So to give you a better understanding of our context, so we are examining this question in the Brazilian healthcare system. Brazil operates a dual system. There is a public national healthcare system that provides universal coverage to its population, but there is also a private healthcare system basically funded by private insurers. The public health system, the focus of this paper, attends about 3/4 of the population. It is one of the largest public healthcare systems in the world. So as I said, we focus on births in the public healthcare system, which account for about 70% of births in Brazil. There are very different dynamics in the public and private healthcare system, but the main one is on the private healthcare system, mothers can basically choose their physicians. So they have a lot of voice in demanding, for example, C-section, and also physicians are paid by the procedure. So they have financial incentives, perhaps, to perform more C-sections. And this is reflected in the different rates of C-section in the public and private healthcare system. Okay, so what are the key features of this setting? Very important. So expectant mothers have no prior relationships with their doctors. So mothers do their prenatal care in local clinics, and unless they are in a high-risk pregnancy, which then they send to a specific physician in hospital, they are only directed to go to the hospital when in labor. So because of that, mothers arrive at hospitals at arbitrary times, so when they are in labor, and they're assigned to the physician who is on duty. So physicians tend to work more like a ER system, so they tend to work with different peers across different shifts. So for example, Carlos might work today with Leandro, and I might work with Marlon the other day. So you are exposed to different peers across a relative small number of shifts. Very important, physicians are the main agent in the decision to perform a C-section in the public healthcare system. So mothers have very little voice in asking the specific procedure. So there are specific norms on when a C-section should be performed. So because of the characteristics of this setting, basically this random variation in patients and exposure to different peers, this generates quasi-random variation in patient composition and the composition of peers. It's not that it's completely random, it's more like a conditional independence assumption. So our argument is conditional hospital times time, day of the week. So these are a specific hospital, a specific day of the week, a specific time of the day. You're gonna see quasi-random variation in patient composition and the peer group configuration. So our final data set has over 5 million births from 2012 to 2019. It involves over 17,000 physicians across 920 hospitals in Brazil. So just to give you a flavor of what we are looking at, so we are looking at focal physician Livia, who in, let's say, Monday morning is working with 3 other physicians. In this case, you have one physician who tends to be more aggressive and perform more C-sections, and then you have 2 others who are less aggressive. Now, let's say next Monday, Liv is working now with perhaps 2 aggressive physicians and 1 less aggressive physician. So it is kind of like this variation that I'm looking at. It is a within physician variation that I'm exploring. For the sake of time, I'm going to just jump all these econometrics, but I'm happy to talk with academics and give them more details on that. So kind of the main finding of the paper, we find that actually working alongside peers who tend to perform more C-sections increases your own likelihood to perform C-section. So 1 standard deviation increase, the tendency of your peers to perform C-section increases your own C-section rate about 1 percentage point. We look at whether this is particularly random. We find evidence consistent with random assignment. We look at the several characteristics of mothers, including whether it's like high-risk pregnancy, mother's age, prior C-section. And overall, we find a very little evidence that the characteristics of the mother are correlated with the characteristics of the peers. After documenting this main effect, we try to understand what's the mechanism driving this influence, right? So in the peer literature, there are 2 main mechanisms. One is peer pressure. So if you work with someone who is working faster, you also tend to work faster for normative peer pressure reasons. Another one is more on the learning or information sharing aspect. So some other individuals might share information, knowledge to you, which you can incorporate in your decisions. So we look at several analyses to try to understand whether the mechanism is about peer pressure or information sharing. The first thing that we look is actually the different types of births. So there are cases where mothers have very little indication for a C-section, so a vaginal delivery is recommended. And there are cases where clearly a C-section should be performed. It is basically in the middle part, when there is higher clinical uncertainty, where you see stronger peer effects, right? In addition to that, we look at experience of physicians. So if it is about information sharing, you typically will find that peer effects should be stronger for the less experienced physicians. And that's what we find. Lastly, to understand mainly like this idea of peer pressure or peer information sharing, we look at times where the maternity ward is really busy. So when the maternity ward is busy, you tend to see stronger peer effects. That means that it's more about peer pressure. However, if you think about information sharing, you really need time. When the hospital is busy, you just don't have time to go and talk to other physicians. And here we find evidence, again, consistent with information sharing. So when the hospital is busy, peer effects are weaker. What I think it's particularly interesting, perhaps, for practitioners and implications is to actually understand what are the outcomes for mothers and babies, right? So will these be related to higher cases of complications for mothers? This will be related with perhaps worse health outcomes for the babies. Understand that actually understanding the relationship between C-sections and these outcomes is very difficult. You cannot just randomly assign mothers to either C-sections or vaginal delivery. So we really need to use kind of quasi-experimental evidence. In the literature, there are mixed results. Certain papers indicate negative effects, and other papers suggest positive effects of C-sections on maternal and newborn health. So we actually use this quasi-random variation in peers to understand the implication of C-sections on health outcomes. What we find is that actually C-sections lead to more complications for mothers, and this means more bleedings and infections. but we don't find any significant impact on the newborn's health measured by the Apgar score at 1 minute and the low Apgar, which is an indicator for an Apgar score below 7. So to conclude, we find evidence of peer influence among OBGYNs in Brazil. We find evidence consistent with an information sharing among physicians, meaning that peer influence is stronger for cases of clinical uncertainty, stronger for less experienced physicians, and weaker during busy times. And in terms of impact for health outcomes, we see that the main implications is more complications for mothers. So more bleedings, more infections, but very little impact on health for newborns. And again, I have to say, this is at the moment of born. If the kid develop respiratory problems at the age of 5, I'm not able to capture that. But at least at birth, we don't see any negative implications for newborns. And I'll stop here. Thank you so much.
Perfect. Good. Bonjour. Good to see you all. That's the extent of my French, so I apologize. But thank you, Marik, for inviting me. Thank you, Carlos and Jafar, for sharing the panel. I am Leo Pongelupe. I'm going to be presenting this research that I'm developing with Laura Dirksen and Nidham Baguerra, that is basically privacy at what cost. We have a bunch of empirical results that we're going to share with you. We are still working on this project, so it will be wonderful to receive your feedback as well. And I want to kick us off putting a scenario here and asking your opinion about it, right? So let's suppose you are living in Malawi, this country in Africa, and you just got tested positive for HIV, right? Then you are filling in the report to enroll into the ART treatment, the antiretrovirus treatment. And one of the questions that the person asking you, several questions, one of the questions is, if you miss an appointment to pick up your drugs, would you be okay with us, the clinic, tracing you back into treatment? In other words, we're gonna reach you out by phone, or we're gonna go to your village and convince you or try to bring you back to treatment, okay? So I will repeat the question. If you miss an appointment to pick up your drugs, are you okay? Do you consent on us to trace you back to treatment? Now I want you to think about this and say, who would say, yes, I consent you to trace me back to treatment? Who would say no? All right, good. So keep that in mind. We're gonna get there in a minute. Okay, so the context that I'm alluding at is the AIDS epidemic. We see that despite reduction overall in the world, we still have 500,000 people dying per year in sub-Saharan Africa because of AIDS. In Malawi, this country in south of Africa, we see that HIV has a 9.5 positive prevalence over time. And the interesting thing is that despite the use of ART treatment that helps patients to contain the spread of the disease and not develop the AIDS, what we see is that most of the people end up lapsing their treatments, right? So they start the treatment, but in the beginning, the first 2 years is when they actually go out of the treatment. They just simply not go back to the clinics to pick up their drugs. Eventually, they deteriorate their health conditions and end up dying, right? So what we want to understand is to what extent an intervention such as electronic medical records help to prevent people from lapsing to their treatments and also help avoiding their deaths and the spread of the disease in the communities. So these are two pictures from clinics in Malawi. This would be how papers, how patient records were registered when they were paper records, right? So you imagine it can be very difficult for clinic staff to know if patient A is actually coming at the right date, at the right time to pick up their drugs. Meanwhile, when the clinics implement the electronic system, they can quickly query the system and analyze, okay, who are the patients that should have come by today to pick up their drugs and are not coming, right? So it's very easy for them to access the information. It's very easy for the patients as well because they arrive at the clinic, instead of having to look at the files or their medical records in paper, they just simply show their health passport, they scan it, with the barcode, and they know, okay, you have to come back at this date, this is the amount of pills that you're gonna take in this visit, right? So we wanna understand to what extent the implementation of these electronic medical records help to reduce the likelihood of patients' deaths. And we also gonna try to understand what helps us to predict the health outcomes such as deaths among patients, okay? So just the research questions that we are trying to address here. So just to give you a little bit more context on the data, we have data on individual level data, anonymized, de-identified, right, to guarantee the privacy of the patients. But we have individualized level data on 755 plus patients throughout 106 different clinics in Malawi, both urban and rural clinics, both large and small, hospitals, and actually only clinics. This data is between 2000, is an unbalanced panel between 2003 and 2018, where EMR has been ruled out over time in these clinics, and we compare, actually they ruled out and backlogged the information of the patients, so we have information on the before and after of the EMR implementation, and we can compare there where they could have implemented, but they did not yet. Okay, we're gonna get a bit more to the econometrics as well. So just to give a little bit more context, we have 358,000 patients still in care in 2018. We have 17% lapse immediately after enrolling in ART, so they simply don't come back for a second visit. And we have that one-third of this patient, one-fifth of these patients end up dying. In total, we have 55,000 plus deaths that are recorded. Usually these are recorded by the clinics or informed by the family. And 6% of the patients actually died in 2 years after their initiation. So again, similar to Carlos, I will not go into much depth here on the econometrics, but what we have is a staggered diff approach. So we're gonna see what is the effect of the implementation of EMR on outcomes such as deaths, controlling for clinic characteristics, and controlling for time of implementation. We also do a several set of robustness checks to test if this is an effect of the implementation of the electronic medical records, or was more a matter of when it was implemented, if your clinic was in the early set of clinics that implemented, or the later set of clinics. We also do, in the end, I will present some of the preliminary results that we have, a machine learning algorithm trying to understand what are the covariates of the patients that help to predict a higher likelihood of them to die because of HIV. And I am sometimes critic of the economists that only run databases, so we also do run analysis on database. We also do field interviews, trying to understand the perspective of the clinic staff, of the doctors, of the expert clients that are the ones responsible to trace the patients, NGO collaborators and local chiefs, community leaders, right? What were their takes on this implementation, so we can have more nuanced results. Okay, so this is the main graph that I want to share with you. Let me just walk you through that. So this dashed line is the EMR implementation, right? So we lined up all the clinics here before and after the implementation. Bless you. The negatives are years before the implementation of the EMR. The positives are years after the implementation of EMR, right? So in black, we have all patients grouped up together. In blue, we have the ones that responded that, yes, they consent to be traced in case they lapse on their treatment. In red, we have the ones that said, no, we don't consent on being traced if we lapse from their treatment, and the ones that have not been asked are the gray ones. Okay? So let's start with analyzing all patients together. So we don't see any pre-trend, so there is no indication that before the EMR implementation there was a higher or lower chances of those patients to die. And we see that after EMR implementation, there is a gradual reduction on the likelihood of those patients or overall patients to die, right? So we can see that there is potentially a positive effect of the electronic medical records on the reduction of deaths. What is interesting is that we have heterogeneity depending precisely on the patient's preference for privacy. Right? So the patients that answer that, yes, it's okay for us to be traced in case we miss an appointment, we don't see that the system actually has any effect, any significant statistical effect on their likelihood or not to die. Right? These patients are usually the ones that will come to the clinic no matter what, so they actually don't care if the clinic will trace because they will adhere to the treatment independently of if they have a system that will trace them or not. What is interesting, especially for the ones that answer no, is that these are the ones that the EMR helped to save their lives more, right? We can see the red ones, they gradually also decline, and they are the ones that that pull actually the average of all the patients to reduce their likelihood of dying, right? So what is going on here, right? The fact is that the system helps to trace the patients better. It's specifically, especially the ones that would be more likely to default or to lapse from the treatment and bring them back to care. And when we go to the interviews, we understand how does this happen, right? So this EMR data statistician told us there is an improvement of patients follow-up, particularly in ART department, because we are able to trace the defaulters easily. And we are able to know who are meeting their appointments, and before it was very difficult for us to identify, right? So it was basically impossible to go over all the paper records and identify the patients that are defaulting their treatment. And now with the electronic medical records, very easy for the clinics to see who are not meeting their appointments. And then when they have this list of patients, what clinic staff do? They go out and they try to, either by phone or by visits, to bring those patients back to care. Most of the staff, they've shown that they have this concern with the spread of the disease in the community and also with the life of the patient themselves, right? So they say, okay, it's our responsibility, it's our duty to guarantee that this person will stay alive and that the disease will not spread through the community. But there's also some ethical conundrum here, because there is a little bit of a violation of the patient's preference for privacy, and there is a potential effect on the stigmatization as well, right? So this clinic staff told us, oh, the patients, right, they have confidence that they will not default on their treatment because we tell them, if you default, we will come, follow you, and people will know that you are taking drugs, and gave a little laugh. So it's kind of this kind of coercion that, okay, if you don't comply with the treatment, we're going to follow you no matter what, and then people will probably discover that you are taking the drugs, that you have the disease, right? So there is this tension between assuring that the patients will remain in care and will have their lives preserved and will have not the disease spread on their communities, but at the same time, using the technology to violate their preference for more privacy. This is just like some robustness checks with alternative econometric estimators to correct for that timing issue that I mentioned before. I will not enter too much in detail here. But then with these results, we were, okay, this is interesting, but would that be possible to build up an algorithm that would help us to better predict what is the likelihood of a patient to die or default or die without necessarily affecting their preference for privacy, right? So what we did, we created a machine learning algorithm, a random forest classifier, in which we test, based on the data set, what would be the variables that will help us to better predict the likelihood of a patient to default and die based on the information that we have at their registration moment, right? So the way that it works, We partition the data set in training and testing data set. On the training data set, we use these classifiers to see what are the variables or covariates or classifiers, if you want to use, that reduce our entropy. That helps us to faster converge to the correct prediction of this person will die or this person will not die. Right? Then we average all those decision trees and their results to get what is the prediction and test on the testing data set. And we see how accurate our model is. So, oops, yeah, this came all together, but that's good enough. So just this slide, first what we can see is that we test both for default and deaths. We see that the accuracy in comparison to a logistical regression model is significant, right? It's quite higher. We see that the random forest classifier, or in other words, the machine learning algorithm, increases almost 20 percentage points the accuracy of correctly specifying the patients that are more likely to die, right? And what we found interesting is that we had information on the clinics, so their location, urban or rural, if they were large or small, if they are hospitals or clinics. We also had information on the patient's characteristics, so if they had advanced HIV stage when they enrolled in the treatment, if they had a supporting person with them at the moment of registration, their age and gender. But it seems that both to predict default and deaths, the best covariate that we have is actually the body mass index of individuals at the moment of their registration. This seems to be the variable that helps us more precisely predict that this patient has a high likelihood of dying or defaulting in the moment that they register, even more than actually the stage of the disease. And what I know that I'm running out of time. This is my last slide. What we found is that patients that have a slightly lower body mass index are more likely to default, right? Are significantly more likely to default than the ones that have slightly higher. And also, if they have lower body mass index, they are way more likely to die. So why we think this is interesting is that we could use the information on this machine learning and implement on the clinics. Then the clinics will be like the banks when they are thinking about giving you a loan for a house. They will have several indicators that will raise a flag in terms of your risk of paying back the bank or not. We could use, similarly, the information on this algorithm, plug back on the clinic's EMR, and that will give the risk of this patient to actually default or die. And then the system will simply say, okay, this is a high-risk patient, just make sure that this patient comes to the clinic more often to pick up their drugs, so it will guarantee that they stay under treatment, and therefore not necessarily will overrule their privacy or not. It's just a way to build in the system build the system in a way that will not force, but that will keep the patient more in touch with the clinic, lowering the risk for those patients and for the communities, and also not overruling their preference for more or less privacy. Finally, my last, I promise, EMR has been extensively studied in the US, but not in other contexts, especially in developing economies. The context in the US shows mixed results, and here we can clearly see the positive effect of EMR on patients' care. We see this reduction in 28% less deaths and 34% more patients in care. We also did a cost-benefit analysis calculating how expensive it was to implement the system in the clinics of Malawi and how many lives it saved. And if we could, not necessarily we should, but if we could put a value on each life saved, it is less than $500 to save a life that is running the risk of dying of HIV. Again, less than $500 to save a life implementing a system like that. So quite interesting cost-benefit evidence. And finally, we see that BMI seems to be the best predictor for likelihood of defaults and deaths, and it will be interesting to incorporate this into medical protocols aiming to address populations that are into risk in contexts such as Malawi. Thank you.
Come on up.
Thank you so much. First of all, I would like to thank Benedict and Marieke for the invitation. Thank you, Carlos. Thank you, Leandro, for your presentation, a great presentation. I would like to share with you some inputs from my side, and then after that, give you a global overview of what's going on in developing countries in terms of the health system, the developing of health system, the role of physician, the role of the politician, and the role also of patient. So let's start with the C-section. Thank you so much for your presentation. The number in Morocco are quite interesting. It's 21% of C-section rates. But if you compare the rural area and the urban area, it's 13 and 27%. And if you go to the university hospital center, it's 40%. Okay, you will see and you will say that it's normal because they receive complicated cases, etc. But when you study the day, for example, Monday, Tuesday, Wednesday, and Thursday, more C-section on Monday, Tuesday, and Thursday, not on Thursday and Friday. Why? Because physicians, they don't want to be blocked during the weekend, first. Second, when you see the price with the government for a C-section in the government hospital, it's 300 euro. I would say, not in dirham, in euro, 300. For the normal delivery, it's 100 euro. In the private sector, it's 350 and 800 euro. So it is more than the double. I'm not saying that all my colleagues, I'm physician, not all my colleagues are, how can I say, more financially oriented to take the decision. I'm not saying that, but I think you understand what I'm meaning. But it's very important. The other information about C-section, I don't know if you have the same cases in Brazil. When you are, for example, seeing the behavior of the population, the women, educated and not educated, we have the double, twice, in the educated woman in Morocco. Twice for C-section. They choose. When you try to segment and to see, let's say, for the educated woman, the number of women that are connected to the social network. And now we find 3 times the C-section. So normal, 2 times, and 3 times. You know, in Morocco, the population is 37 million, and you have 40 million phones. In Morocco, we are more connected with the network than in water and assainishment in some region. So the social network is very important. Very, very important. So we can use it. It's very important, but we will discuss about this. And the final point about the C-section is that physicians, they adapt to the system. When the price of the C-section increase, we see in the region that the behavior of the physician is following the increase of the price. In other region or hospital, when the price is decreasing, the C-section is decreasing. If, for example, we say some physician and the young and the older one, you will work in Monday, Tuesday, and Wednesday. They change their behavior. I'm talking about the C-section to give you some information about the C-section. Let's talk about the digitalization of the C-section, the system. You know, HIV prevalence in Morocco is 0.07%, the global population, but in vulnerable population, it's between 3 to 7%. If we are talking about men who have sex with men, sexual professional, etc. But the digitalization is not making a problem for the government, or not making a problem for health decision maker. It's making a problem for physician. You know why? Because of taxes. Because of taxes. They don't want a strict follow-up of the information. Because if you digitalize the system, if you digitalize the medical record, we have the information. It's not a problem of the symptoms, of the clinical diagnosis. It's about the number of patients they are following. And if you have the number of patients there following, it means Ministry of Finance and Economics. It means taxes. So we have to find a way that physicians comply to this very interesting system because it saves lives. And also for the compliance. Why I'm talking about compliance? Because, for example, if you say, let's talk about non-communicable disease. You know, the first cause of deaths in Africa, in Morocco, it's not infectious disease. It's non-communicable disease. In Morocco, for example, 80% of all the deaths are due to non-communicable disease. Hypertension, diabetes, cancer, and renal failure. This is the main cause of death. And more in Africa also. Africa, we have infectious disease. In Morocco, we have the same epidemiological transition. We have infectious disease, of course, but we have more and more now non-communicable disease. And we will talk about the consequence of this epidemiological transition. So the problem we have is that, for example, for hypertension, 71% of people with hypertension and with treatment, they don't comply to the treatment. So this procedure will be very great to make people coming back to the physician and following their treatment. For diabetes, we have 50% of people that don't comply. And for tuberculosis, we have 20%. And I'm saying something. In Morocco, diabetes, hypertension, tuberculosis, the treatment is free of charge. They don't have to pay anything. You can go to any primary healthcare center in the country. It's free of charge. So it's not a problem of financial access to treatment. It's free for everyone, even for migrants in Morocco. If migrants they come in Morocco, they have tuberculosis or hypertension or diabetes, it's free of charge. And even though people, they don't comply to the treatment. So this solution could be very helpful. So if I can, from your two presentations, your great presentation, talk about the global aspect, what's going on in the health system in developing country, in Morocco and in Africa. There is a big shift because all the politicians, they want to give access to health services to all the population. Because for political reason, for social reason, it's very important. And Morocco is going to give to all the Moroccan a health insurance, a national health insurance, like in France. The problem is that when you want to give the health insurance to everyone, it's like you give a credit card without money in the bank. So I can give you a gold, a Visa or a MasterCard, but if you don't have money in the bank, it's a problem. So if you want to give to everyone a health insurance, a national health insurance, you need to give them the services. So Morocco, for example, we went from 15% of the coverage for 15 to in 2024, 100% of the coverage. 15 to 100. But for what type of services? People now, they have access to all the services. I'm talking also about South African countries, to the public sector and also to the private sector. Because more and more in Africa, the private sector is getting stronger. In several countries in Africa. Why the private sector is getting more and more stronger? Because the government cannot give all the services, give all the how can I say, the curative and preventive services to the whole population. Because, of course, and we say in French, la santé n'a pas de prix, mais elle a un coût. Who will pay? Give you one example. If you take, for example, the budget of the HEC in Paris, it's 9 billion euro. It's 3 times the whole budget of the Ministry of Health in Morocco. The HEC, I mean the network of the hospital in Paris, 3 times. If you check the national insurance in France, for example, it's 600 billion euro. It's 300 times all the social protection in Morocco. 300 times. So we're not talking about the same number. And if in the developing country now, African country, Morocco, for example, you have more and more non-communicable disease. Non-communicable disease, it means people, they have to get their treatment on a long-term basis. Diabetes, hypertension, cancer, etc. Who will pay? Because it's not for 1 week, 1 month. It's for 10 years, 20 years, 25 years, I don't know. Who will pay for that? So let's now talk to the out-of-pocket. You know the out-of-pocket in France, for example. It's the maximum between 7 to 8%. In Morocco, the out-of-pocket is 60%. The median in OCDE is 25%. So 60% of all the health expenses are paid by the households. And more you have non-communicable disease in African country, in developing country, the more people they have to pay. Otherwise, we have to find a solution to finance the health system. So let's give small numbers. If you take, for example, diabetes, the median in Africa, I'm not saying, of course, you have Egypt, you have Tunisia that have specific number. But let's talk globally. 30% of adults, they have hypertension, between 29 to 32%. Diabetes, it's between 10 to 12%. And cancer, it's approximately between 30 to 40,000 new cases each year. And HIV and in sexually transmitted disease, 600,000 in median each year. So you have this epidemiological transition, you have the demographic transition. You know that we are saying every time, African country, they are young people, very young. Yes, of course, but we are getting older. For example, in 2050, 25% of the Moroccan population will have more than 65 years. You know how many geriatrics we have in the country? 7. 7. How many geriatrics there are in Africa? And in 2050, more than 15% in Africa, they have more than 60 years. So we will have more and more cognitive disease, Alzheimer, Parkinson, etc. It will cost for them. And finally, something very important, because we want to give the universal health coverage to everyone. We want to digitalize, to have the information, not only to save lives, but also to have the information for the patient journey. And we want also to let people have access to all the services in public and private, but we let the private grow. During the last 10 years, please see the number. During the last 10 years, the growth of the private sector in Africa, 3 times the public sector, 3 times. If you see the number of hospitals, of primary healthcare center, compared to the private clinics and to the cabinet, the private cabinet, 3 times the growth in Africa, compared to the public sector. It means that the government is doing what he can do, but not pushing too much for giving more and more money in the public sector. It is the same pathway like education. Exactly the same like education. See the number of education in Africa. I'm talking also about Morocco. We're moving from the public, to the semi-public, to the foundation, to the private. Because we cannot afford to give all the services, the best quality we can for everyone. So we have to choose. So what will be the criteria to choose? Who will have access to all the services? What is the minimum packet of services we have to give to people? Who will pay? And for what kind of outcome, of output we want? Better health, better quality, less death? What do we want really in terms of output and outcome for developing country? In terms of access to health services, quality, and performance. Last thing I would like to see when you compare, it's very interesting to see the paradox. When you compare, for example, the deaths and the morbidity during the COVID-19 pandemic, when you compare, and we did an article about that, in African country, developing country, and developed country, it's very strange. We have better number in developing countries, in Africa, in terms of death, in terms of morbidity. Or because of the statistics? I don't know. Because why we have a little case fatality rate in developing country and in Africa compared, for example, for European country? Because we have better physician, better infrastructure, more money in health. So look to this paradox we may have between developed country and developing country. And my last word, I hope I respect my time. My last word is to see that, and to share with you one thing very important, is health and education are the most sector that are, how can I say, a social bomb. And politicians, they have and they should put the maximum for health and education, because otherwise, I'm talking about African country, it's a very big risk if people they don't have access to education and not access to health. Because a woman, a man, a child not educated, it's a danger from the social point of view. People that they see their child, their husband, their mother, their wife not having access to health is also a risk. So who will pay for this risk? We have to think about. Thank you.
Questions, please. You have 25 minutes or so for questions.
Thank you all for
following treatment because of the side effects of these medications. So, for example, for pre-diabetes and diabetes, metformin is the treatment, right? Or hypertension is propranolol. But these are medications that have really, like, real consequences on the day-to-day life of certain people. Some people don't react to it. Has anyone in Morocco or anyone in management, I don't know, studied this? Because there are no, I don't know, I mean, there are no options, right? And you have to live with the consequences, so thank you.
It doesn't work? Yeah, that does work. I'm Amina Alaoui. I'm from UM6P here, based in Paris, and I'm interested in what the last developments concerning access to health and also education, as pointed out by Professor Jarfat, and afterwards. How do you think, as we are talking on inclusive economy, we can define the minimal access to education and health to be defined? Like how can we give some maybe international working group at WMO or something like this to define what should be the contribution of the policymakers or the governments for the whole population, as we see that you pointed out, governments don't have enough money to pay for everything. So should we make something like we did for education, that is primary education is at the charge of the governments, and then maybe the second part could be parts of like private sector, and on health side, what should be the minimum package? Let's say government should take into account, like we said, HIV, for example, is just a spreadable disease, so maybe it could be inside the package, or what should be the criteria to take into account? Thank you.
Yeah, thanks so much. A question to Carlos and Leandro, and I'm sure this must have been very difficult to collect all this data. So kudos to you guys. Maybe to Carlos. So my sister is a doctor too, and she somehow always gets to share shifts with her friends. So is there really no selection in the sort of shifts? That's one. And the other one, I'm just wondering, like, how much information could there be shared with C-sections, given that it's such a standard procedure? So I'm sort of curious about that. And to Leandro, very interesting. The one thing that may be, a statistical comment, when you use these sort of more modern estimators, the Sun and Abram and so on, the tracers do go down and don't look very different from the non-tracers. So I'm curious where that's coming from. Thanks.
Yes, Yoshan. I wanted to ask you, Mr. Jafar, talking about the paradox of the numbers of deaths concerning the diseases. Does it count the statistics of people who doesn't have the access to medical treatments and or the ones who come in the critical state, or it's just in general with just what you have? And voilà, thank you.
I'm a third year student of economics, and my question is for Mr. Leandro. I would like to know, how do you manage with people in rural region of Africa? Because I know that in those regions, people don't have like cell phones on tools to communicate with hospitals. And how do you manage with them to not stigmatize them in going to trace them at their home, talking about the diseases?
Hello, my question is for Leandro. Emmanuel, emergency physician. How can we know that the link between BMI, body mass index, and antiretroviral therapy, the observance, of the ART is not a spurious correlation?
Good morning. My name is Catherine Gibois. I am from Doctors of the World. My first question will be to Carlos about the C-section. You raised the issue of the private versus public sector, and it has a strong impact on your data. I mean, the rates are amazing in Brazil. I was appalled. But I was wondering to what extent you have some idea, and it was in your study, because at the end of the day, it's a surgical procedure, so by definition, it has more impact than a vaginal delivery. But for the 15%, let's say, as an average for which is recommended by WHO, it's a life-saving scheme. I mean, it's a life-saving procedure. So, did you have any information about the I don't know how to say it. It was not relevant to make a C-section among the 55%. And there was another question for Leandro is, did you have any, did you make any correlation, not correlation, but comparison with what happened it was a long time ago in developing countries, the system for TB patients is the DOTS approach for TB patients and how they can relate with what you are doing in Malawi, which is very interesting, in fact. Thank you.
Such great questions. Let me start with more like the broad question, thinking about the future of healthcare systems. I think as we try to increase access, expand access, provide healthcare to more people, I think we also need to understand whether healthcare systems can be more efficient, right? So where is the waste? Where is that, that we could shift, make small changes so that we can sometimes like save money. So in my case, thinking about C-sections, if some of them are really unnecessary and leading to higher healthcare costs because it is a surgical procedure, so this is an area where we can perhaps try to educate doctors and mothers to pursue a procedure that is perhaps sometimes safer and involving less costs. In addition to that, understanding these different mechanisms, so in my case, peer facts, but as Jafar was saying, the influence of financial incentives could be another way of reducing waste in healthcare. To Anselm's question, the main challenge for us is really thinking about self-selection of physicians to specific shifts. I might want to decide to work on Mondays mornings. So our idea is to use hospital times, day of the week times, hour of the day, fixed effects, so we could netting out any self-selection into specific shifts. So let's say that, as Jafar was saying, most of the cases are like C-sections happen to be on Monday mornings. So we are eliminating all that kind of like self-selection into specific shifts in that hospital. We also have some additional robustness checks by looking at physician times, day of the week times hour of the day. So basically looking at all, whether just like variation in your peer composition for specific days of the week and times of the day. So that's what we try to address some of these concerns of self-selecting to specific shifts. To the question about differences in the public and private healthcare system, at least in Brazil, this is motivated by financial considerations, and not only financial considerations, but time considerations. If you think about a physician, is much quicker to perform a C-section than actually having to attend a birth for perhaps 12 hours. So there are, things that would perhaps push physicians to perform more C-sections. In the private healthcare system, there is also the role of financial incentives. They're paid by the procedure, and typically they are reimbursed or paid more by C-sections. So that creates a large differences in C-section rates in the public and private health system in Brazil, at least. So
Yeah, thank you so much for the questions, and thank you, Jafar, for, there's so many interesting aspects, right? Like how much the government should pay. I mean, we tend to think about physicians as, a doc from the economic world, right? But how come a physician wants to get higher pay? I mean, we all want, right, to some extent, but then how can you design the incentives such as that you don't deliver a worse quality of health? But going to the questions here, so regard the tracing and the staggered models that Anselm was raising, so we did some analysis with also those alternative estimators for the trace no, trace yes. So it holds for some of those estimators, if I remember by heart, I think Callaway, Santana, and Abraham Su holds, and some of the others, they don't hold. I might be mismatching them. So it seems that there is might be a timing effect with like the trace no's and trace yes, depending on which estimator you're using. So happy to follow up more, especially because those literature is so recent that I think every day there is a new estimator for those staggered models, right? So anyway, those econometric jokes, you see, nobody laugh. Sorry, guys. We are going to nerdy deep territory. Anyway, rural population stigmatized, thank you for the question. So yes, this was something that we were highly concerned about. I mean, this just, the implementation of the EMRs was not done by us. It was a partnership by the Ministry of Health from Malawi with an NGO called Baobab, and they implemented the system in several of the government clinics. And we took advantage of this implementation to do the impact analysis, right? So somebody raised the question about how you analyze impact. That's kind of like, usually what I try to do is partner with organizations to develop the impact analysis. But this, I think, goes straight to the point that the system facilitates to identify the patients that are lapsing or defaulting, and then, to some extent, bringing the patient back to care, expose them to a higher level of potential stigmatization. We had interviews with clinic staff and expat clients that they said, oh, when we go to some rural locations, if the patient is trying to avoid us or don't want to come back to care, we go to the local chief, and then we talk to the chief, so the chief starts coercing the person to go back to care because don't want the disease to spread. And the chief told us during interviews that, like, okay, it's either you go back to care or we're gonna, kick you out of the village. So there is that. I think that's the tension that I think somehow we lived a little bit during COVID. That okay, technology can help you address many issues regarding healthcare, but at the same time it can violate privacy in others, right? So where do you draw the line? What's more important, your health and the health of the community, or your preference for privacy? But thank you for the question. About the BMI potential spurious correlation, so what we did, this is was your point, right, Amanda? So the random forest classifier is not a quasi-experimental method. So we are not trying to identify what causes the death. What we are trying to do is, based on the set of characteristics of clinics and individuals at the moment of registration, can we analyze which one of these characteristics helps us to predict better the likelihood of this patient to die? And what we see is that, for instance, BMI is the champion. There are weights on the others. So instead of necessarily asking the patient, oh, do you consent to trace, and independently of their answer, just go after them, they could use this information on the system, and then now, like, if I'm profiling a new patient and I see, okay, this person has a very low BMI, has this characteristic, the system would raise the flag, okay, this is a high-risk patient, and then with the help of clinicians, we could design protocols that the system say, oh, okay, instead of making the patient come back to pick up their drugs every 3 months, make them come back every month or like in two weeks. So they try to keep the patient more attuned with their treatment. But again, this would be an area that I think there's a lot of benefit on talking to physicians and understanding how to do. And finally, TB patients in Malawi, that was the other question, right? So we have information on the TB records, especially because it's highly correlated also with the development of HIV. We did some analysis with that. I'm happy to talk more about it. The system was not designed only for ART, so it was also for other users, if you're going to the clinic for other users. So I'm pretty sure it might have also some effect on the tuberculosis index. We have this analysis. I don't remember it by heart, but I'm happy to talk more about it. Thank you.
Thank you, Carlos and Leandro, for your great presentation and discussion. Sandra, American, they say perception is reality. Thank you for your question. It's a very important one. We ask Moroccan people why. It's not because of side effects. You know why? Because they don't trust the government, because it's free of charge. It's not normal. So we did a study about insulin. And we gave the same insulin in primary healthcare center and in the private cabinets. The same insulin. The same, with the same lab, etc. And so they went from the primary healthcare center in the public sector, they went to the private sector, and they buy it. Crazy. For tuberculosis, exactly the same. It's free of charge. We have 30,000 new cases of tuberculosis each year in Morocco. It's a public health problem. It's free of charge for everyone. But they say, it's not normal. Why they give us these drugs free of charge? We had the same problem this year with HPV vaccination for girls. It's amazing. And the government, the Ministry of Health, we bought all the vaccine free of charge in all the primary healthcare centers. Why they give us this vaccine free of charge? We had some turbulence with COVID-19 vaccine, and now they want us a new vaccine for our girls free of charge? It's not normal. So we have to educate people. We have to more and more do health education to explain the interest of vaccination, of drugs, etc., etc. Because we have more complication with diabetes and hypertension in the country, not because we don't have clinicians, not because of the natural history of disease, because of the problem of compliance with patients. So this is a problem. It's not really a side effect, unfortunately. The second question from my compatriot from Morocco about the minimum package. We had a great discussion with WHO and many countries in Africa, and sometimes they tell you, okay, WHO said this is the minimum packet of services. I answer, WHO is not Quran or Bible or La Torah. WHO is orientation, it's people like us. It's not a prophet, WHO. It's consultant, it's expert people, great people, but they give us advice. Not something that we have to absolutely respect because the health in Morocco is completely different from France. I cannot apply your health system. If I apply the health system, the French health system in Morocco, it will be a bankrupt, it will be a nightmare for Moroccan people. But we have great things in France in terms of your social services, in terms of the health system, but not specially applicable to the Moroccan context. So the minimum packet of services, should be built by people at each region level. At each region level, it's totally different. Of course, there is a minimum basis, a minimum that to give access to people, preventive services, before curative services. But let's study all the budgets of all the African countries in the health system. They put 70% of all the budget in curative services, not in preventive services. If we put more money in preventive services in all African countries, we may save, listen to me, we may save, listen, nearly $180 billion each year. $180 billion each year, only by asking more effort on preventive services. It's not the case. All the government study the budget of African countries for the health sector. 70% approximately, between 70 to 78% on curative services. This is one crucial issue we have to think about. The last point about COVID-19, about the medical trend, what happened in COVID-19 in African countries and in developing countries. Of course, we may say they don't have statistics. People, they die, we don't know. We don't know the real cause of that. But there are some trends, you have some numbers that explain what happened. And the majority of data we have is about the resilience of the system, the capacity of system to mobilize resources. Like in France, like in Italy, like in Spain, to mobilize intensive care units, specialists, intensive beds, reanimate, etc., etc., etc. There are so many causes that explain what happened during COVID-19. I invite you to study one publication from Johns Hopkins about the impact of shutdown and all economic issue on the health services. And we did this study for 4 African countries, including Morocco. And during the COVID-19 crisis, we have less than 45% of use of health services for diabetes, hypertension, and cancer. So people died, they didn't use, of course, they died because of COVID-19, but we have other people that died because they didn't have access to health services, and specifically for diabetic people, hypertension, and cancer. Minus 45%. This is a huge number. It is why, and I would like to conclude with that, is that we need the help of academics. We are people of the field, but academics could play a very important role. HEC could play a very important role to train physicians and to train health decision maker. Because at the end of the day, we see that the main problem we have, of course, we have finance, etc. The main problem we have in the health system in developing country is governance. It's governance. So we have to work on that, train people, train physicians, train a health manager in different countries in order to help them to manage more, to understand more people, physicians, and the whole system, the performance of the whole system. Thank you.
All right, thank you. That was a great discussion. So it's time for lunch. We will have lunch upstairs. You can leave your stuff here. We come back here at 2 p.m. sharp. We will start with a surprise, which is that someone from FIAP will come and say a few words about the building, because there is this interesting history about this building, and we'll listen to that before we get into the next session. So please join me in another round of applause for our great speakers. Thank you so much.
Should we charge?